Sorry I couldn't be there. For those I haven't met, I work at the Burnett and I'm a PhD student at the University of Melbourne at the moment. I'm not going to talk in detail about our work in PNG and Daru. I usually give an update. Kai will be speaking tomorrow. I will get to that as a component of this talk around TB prevention in high MDR transmission settings. Just acknowledging the funding that supports our work through the Australian Government, NHMRC, MRFF, and my own funding. So we all know that a comprehensive approach is required to control and reduce transmission of tuberculosis as per the WHO TB strategy, of which one of the key pillars around the model of care is around TB preventive treatment. And in the WHO modelling, the combination of active case detection and treating latent TB infection or TB infection is shown to lead to declines in TB burden. However, the scale-up and on-the-ground implementation of TB, or TPT, I'm going to refer to it ongoing, has been slow. We have a target through the UN high-level meeting to treat 30 million people by 2022. Going okay for HIV with 88% there. This is a 2019 midpoint review, but going very slow in household contacts, including young child contacts, but particularly in those contacts who are greater than 5 years. And there has been an increase, but still the pace needs to be picked up. There has been revision of WHO guidelines for TBT in March of 2020. And the changes, just going through the groups here on this side, were unchanged household contacts under 5 and people who have HIV who don't necessarily require a test and can go on to prevention. But there's a conditional recommendation to include all household contacts, including older children, adolescents and adults who are over 5 and consider a test, but not necessary, and also a conditional recommendation for people who have MDR TB. There's a consideration for other groups. There's no recommendation for community-wide test and treat approaches as yet. In terms of the regimens, we have some shorter regimens emerging, other than the 6 months of isoniazid with rifampicin, 3HP, 3RH, and the 1 month regimen that's being rolled out in some settings with HIV. For MDR TB, however, and Greg is going to speak to this, so I was hoping to follow him, and I'm not going to cover the details of the treatment regimens or trials specifically, other than to say that there are 3 RCTs ongoing. The optimal regimen is not known. Observational data exists where there have been 1 or 2 drugs, including later generation quinolones plus another drug. So the point around community-wide approaches for TB prevention, we always have to refer back to the seminal studies in Alaska by Comstock and colleagues that did show that the combination of TB prevention plus active case finding reduced TB transmission, infection, and that was sustained over a long period. Modelling has also backed up this approach. Our group, in collaboration with regional partners, Menzies, IMR, UGM, have been working on fast-track sites trying to take forward active case finding and TB prevention in Daru and PNG. The plan was to go to other sites. I think Chris will speak to the work in Papua, and then Yogyakarta, you've heard Rena speak earlier today. The pandemic has had other plans for this progress. However, this whole concept of how we can actually deliver these models in these high burden settings links nicely to the work in Kiribati through the Pearl study and also in Vietnam. So the challenges I wanted to just touch on today are firstly, some of these implementation considerations when you have high levels of MDR TB in your program where you want to do TBT. Firstly, there's the issue of exposure. And there are limitations, as we all know, of the tests for TB infection. It's an indirect test. It's not measuring bacteria, and you're unable to test for resistance. An epidemiological question is exposure occurring for that person in the household or largely in the community? Transmission, I should say, occurring in the household or in the community. And the issue of age-related exposure is something I'll go into in subsequent slides. The second issue is around the optimal screening and management algorithm, the role of testing, which groups do you test, Do you go community-wide? How can you streamline household visits and also importantly exclude active TB, especially in adolescents and adults? And finally, around TBT treatment, and I just want to posit today this issue around regimens and when really I don't think we've got the fundamental understanding to know if prevention for MDR TB could also treat drug-sensitive TB latent infection, or similarly, if TBT for drug-sensitive TB could also potentially treat drug resistance. The other issues I won't explore in detail are around uptake. These are critical issues, perhaps more important around adverse effects, health promotion, community engagements, and models of care to deliver the intervention. In terms of the age-related TB infection, the coloured graph is active TB in Wipro and CRO regions, respectively, showing that active TB notifications are reasonably high in young adults and adolescents. Lower in kids, probably because of the diagnostic issues, but certainly cases increase over that age group. This modelling study from some time back looked at the prevalence of latent TB infection by age and WHO region, and estimated that overall a quarter of the global population has TB infection. However, it just showed again, you can't see the age groups, but the sharp increase in LTBI with age over time. Again, the main finding was that most likely people are infected soon after exposure in the first couple of years, and over time in high burden settings, adults carry over infection through the TST positivity rates or the testing positivity rates. There was a subsequent study based on that looking at the global burden of latent MDR TB and trying to model what this might look like. And it looked at historical rates of infection and linked that with the trends of the proportion of MDR in new cases. So if anything, that would underestimate MDR burden overall. It concluded that there was a global prevalence of around 0.3% or 19 million people in 2014. The latent MDR TB was increasing in all regions, and that was proportional to the increase in proportion of new MDR active cases. 1.2%, apologies, of all MDR TB was due to MDR TB strains, and it was higher in children under 15, so almost double the rate. There was a peak between the age of 20 to 35 from this modelling study. So this high risk of children and young adults was independent of contact with active MDR TB. It was postulated that it was due to primarily just transmission of MDR TB, and perhaps also that the current generation of adults are partially protected by previous drug-sensitive TB infection. Now, looking at this issue around regimens and also what we find in MDR TB households. So a systematic review from some time ago in 2014 showed that in high burden settings, which is a sub-analysis of this, it included both low and high MDR transmission settings, that the yield of active TB, there's a decimal point there, was 7.87, not 78%. And for latent TB was 52%. So the high rates of active and latent TB in people in households with MDR TB. In the sub-analysis, it showed that there were about, we're only talking about 300 or so cases that had concordance between secondary cases and the primary case. And the majority, 75%, were concordant on the drug sensitivity testing, i.e. if they had MDR TB index case and there was a secondary case that had MDR TB, but 25% were not. I think that's important to note. Most studies didn't look at where transmission was occurring, whether it occurred in the household or in the community. So the WHO guidelines currently have this algorithm where you look at primarily household contacts as your main focus, and that's mainly because households are a very feasible model to deliver TBT and follow-ups for. However, if you are going to expand that, this algorithm may need to train, and you can see it's quite complicated for health workers to follow. You have to look at ages, look at different tests, and then move people around these various algorithms. So I'll come back to this later on. Finally, looking at drug resistance and TB infection, this was a very interesting study published last year from a group in Peru that looked at household contacts of adults over 15 in Lima. And there are about 4,500 index cases and 15,000 household contacts in a long cohort study. They gave TBT as per the program for child and adolescent contacts in the household up to the age of 20 and adults who had comorbidities, including diabetes. So what they found was that household contacts who received TBT with INH had a low incidence of TB, even when they had been exposed to an indexed MDR TB patient. So you can see here the breakdown between susceptible TB, MDR TB, and actually, interestingly, there was a slightly worse trend. There wasn't a benefit with monoresistant, but MDR TB was. So this was quite unexplained. We're not going to conclude that INH works for MDR TB latent infection, but there's really not a plausible mechanism to explain this. They did show that there was no low-level INH resistance in the cohort or through DST in this program. As I said, most secondary cases were linked and concordant to the index cases in these cohorts, but there could have been confounding, and hence these RCTs are really critical to look at the effectiveness of these regimens. An area that I've really got very limited expertise in is around the biology of TB infection. And I think an important question to put out there is how important is drug resistance for treating TB infection? Phenotype of the bacilli is important in terms of latency and dormancy. There are known subpopulations of different types of TB within granulomas, but also within lesions among individuals. Bacteria actually may not be quiescent in people with latent TB, and people have shown that actually they might be more metabolically active, and therefore drugs such as isoniazid and rifampicin may actually work better. So existing tests can't resolve this phenotype and nor the resistance profile. There was a study recently in Lancet ID last month that looked at a microRNA blood biomarker to guide preventive therapy. It did show it could discriminate between active and subclinical and infection. However, it didn't show that when people got TBT that it led to lower rates of TB infection overall. So moving now to the real-world example in PNG and Daru, and really been working towards these next steps for some years, and very much hindered by the COVID epidemic in the country and the pandemic broadly in terms of progressing this program. I won't go through the background in the interests of time, other than to say there's a high transmission MDR setting in the Western Province of PNG and South Fly. We have implemented, and I've presented this a number of times, TB preventive therapy for young child contacts under 5, both for drug-sensitive and MDR TB. And for about a cohort of about 350, we've shown high rates of uptake, 99% high rates of completion. We've had a very small number, 12 children who had levofloxacin for 6 months for MDR TB contact. So overall, across all the various regimens since 2017, we've had an 82% completion rate. And as Angela showed and discussed earlier today, the key ingredient was the health promotion, the health literacy, and engagement of kids in a community-based model of care. The data that came out of this corresponds to the modelling I showed before around the age-related incidence of TB infection in households. So these are drug-sensitive and MDR households. There's a sharp increase in adolescents, low rates in those who are under 5. And in the active TB rates, which I haven't got on graph, but almost 70% of notifications are in those under 35 years. Therefore, we postulate that the transmission is occurring outside the household. It's occurring widespread in the community in this setting. So therefore, the proposed intervention is a community-based and community-wide approach for screening of active TB and treatment of TB infection. This is similar to the Pearl study in that, one, it's funded by the MRFF, but the model is very much the same. However, the difference here is the high rate of MDR transmission in the community. So the first objective, firstly, what we're working on now is community engagement and health promotion. We've created a community advisory group and have started that activity. Just talking through the implementation steps, the first step will be to re-enumerate our households with just age-related numbers and assign IDs. Secondly, we'll first visit will be detection and treatment. There'll be a symptom screen and X-ray with this mobile X-ray with CAD for TB for those over 5 years. If screen is positive, there'll be a mobile clinic, such as this clinic here, where there'll be a clinical assessment and diagnostic sample. Treatment will occur as per routine program. For the prevention component, so after active screening, there'll be a second visit we propose for prevention, where households will be classified as no TB, drug sensitive, or having a MDR TB index case, not a contact. I'll walk through this this approach where we propose that TST will be then administered to those who are aged 5 to 34. We think that's the group that is generating most of the transmission in the community. We'll provide TBT for those under 5 as per guidelines, i.e. if they have an index case in the household, they'll get the corresponding regimen. But for those who are older than 5 and up to 34, if they're positive, we propose a novel regimen that's a combination of 6 months of isoniazid and levofloxacin. Obviously, there's pros and cons to this approach with adverse effects, etc. To those who have not had a TST positive, who are negative, we'll offer BCG vaccination up to the age of 35. There'll be follow-up for up to 24 months, including those who decline the intervention, and it'll be a community-based household model of care, very much led by community members and peer supporters. Enablers will be a part of this intervention as well. I'm pleased to say we've got ethical approval from P&G. We're working through them, the Australian Ethics Protocol now. Here it is in a graphic, just showing the split between under 5 and then the older group around the screening, the detection and treatment part here. And if they're over 35, they'll get TST and go on to this regimen here. If they're negative, they'll get BCG. Young kids will have a regimen as per index case. And if they don't have BCG, they'll get a BCG catch-up.
Min, you have 1 minute remaining.
Last slide. Great timing. Thanks, Emma. So this is the algorithm just in another way, and just to illustrate that it is very complicated across those steps. So we're trying to get this very simplified, and certainly appreciate any feedback or question. So a thank you to the huge team that I get to work with in Australia and in PNG, our partners, the Provincial Health Authority who lead the work, and particularly the frontline health workers and heroes. There has been an increase in COVID in PNG, and COVID vaccination is the priority now and will be for this year. So this intervention will be on hold until next year, until we get through vaccination. Thank you.
Thanks very much, Suman.